let's not knock the water out. We have a full program, so we need to get started immediately. Okay. Well, welcome again, everyone. Linda Gale Becker, President of the International AIDS Society, International Chair of AIDS 2018. This press conference is being live streamed on the AIDS 2018 website, and an archived recording will be available there soon. So, of course, as usual, I'd like to welcome everyone who may be joining us online. So the theme of today's press conference, an important one and one close to my heart since I'm born in Africa and live in South Africa, it is known as the Sub-Saharan Africa New Insights, New Impact. It is the region hardest hit by HIV, and I think absolutely correct that we shine a focus on this region at this press conference today. Today's studies show that there continues to be very encouraging progress across the region, but those challenges that are being discussed at this conference, of course, lie ahead. And I want to announce that at this moment, the embargo on all 5 studies will be lifted. So, without further ado, I'm going to start with our first speaker, Alea Khalifa of UNICEF. She'll be sharing the results of a sobering new study on the future of HIV among young people in sub-Saharan Africa. It's important to remember that you're about to hear results that are not inevitable. If we continue to make good use of prevention tools and accelerate that research, I believe we can perhaps turn those numbers around. But I'll leave it to Alea to tell us what her study shows.
Sure. Thank you, everyone, for having me today. I'm honored to be here. So we all know the world is committed to ending AIDS by 2030. However, demographic shifts in various regions could threaten this global progress. In particular, the child population in sub-Saharan Africa is expected to increase from 500 million today to 710 million in 2030 and keep growing to 960 million in 2050. And those are children under 20. This region is also home to over 80% of new infections among children and adolescents. So we decided to project the epidemic, working with UNAIDS and Avenir Health, to demonstrate how these demographic changes will impact the future of HIV for young populations in 2030 and beyond 2030. So if recent trends of HIV incidence and ART and PMTCT coverage continue, we estimate that by 2030, the number of children infected with HIV through vertical transmission could be half what it is today in 2030. However, for adolescents, the future is different. We don't think we could decrease by half, given current trends, until 2050. Among adolescents, this trend is different. For girls and boys, we project faster decreases for girls compared to boys, although girls will continue to share the brunt of the epidemic. In sub-Saharan Africa, we expect over 5 million new HIV infections for children and adolescents between now and 2050 if current trends continue. So that's over a 33-year period. Looking closer at Sub-Saharan Africa, we found that by 2050, Eastern and Southern Africa will contribute less and less to the global burden of HIV, while by 2050, West and Central Africa is projected to replace Eastern and Southern Africa as the leading region with the leading contribution of new HIV infections for young populations. So these results serve as a warning, really, the need to plan for an epidemic that is not over. Our findings also signal that certain populations are being left behind by region and population. And finally, our findings confirm that we are not on track to end AIDS by 2030. So it really points to the needs to intensify efforts. Finally, we estimate that in 2030, there will still be 1.9 million children and adolescents living with HIV. And so this really calls for sustainable support, care, and treatment, and better planning for future generations. Thanks.
Thanks, Alea. Now I'm delighted and honored to introduce our next speaker, Dr. Bernard Hafiku, who is Namibia's Minister of Health and Social Services. And I'm pleased to tell you he has very exciting and inspiring news to share about Namibia's efforts to increase its third 90 along with its general response to HIV. I know you're all looking for a sign of hope in the fight against HIV, and I think this is a shining example. So congratulations, Namibia. But before I steal any more thunder, I'm going to hand over to Dr. Hafiku.
Thank you very much, Linda. Good morning, everyone. I'm proud to join you here today in Amsterdam at the 2018 AIDS conference to share with you our result of the Namibia population-based HIV impact assessment called NAMFIA. NAMFIA was funded by PEPFAR through CDC and implemented in partnership with ICAP. This nationally representative HIV-focused household survey was conducted in 2017 and involved every region of the country. The country has got 14 regions. Over 23,000 participants took part and provided blood sample for home-based and laboratory HIV testing. The result shows that Namibia's 1999 indicators are at 86%, the first 90, and 96%, the second 90, and 91%, the third 90. This means Namibia is already very close to the UNAIDS 1990 target for 2020, 3 years ahead of schedule. And so we are on track to control the HIV epidemic through our HIV prevention and treatment programs. And in fact, Namibian women have already reached the 90-90-90, something our whole country can now celebrate, and together with our partners, of course. So we looking at viral suppression among all adults, regardless of awareness of diagnosis and regardless of ART use. Namibia has surpassed the 2020 international target of 73% with 77%. So what it means is that we are at 77% instead of the 73 or below. Sounds clarified. So 77% of those living with HIV are virally suppressed. This is a marker of effective treatment and will help us with prevention because, as you all know, treatment in itself is prevention. The result also show lower HIV incidence when compared with the previous years or 2015 modeled estimate from UNAIDS. Directly measured incidence was 50% lower than it was 5 years earlier. So taken together, ladies and gentlemen, these NAMFIA results show us where our program has been the most successful, where we will have to work to, we will have some work to do still, and how to get to epidemic control from all populations in Namibia. We can now see that AIDS-free generation is within our reach. I thank you.
Well, thank you, Dr. Hafiku, and again, congratulations as Minister of Health. I'm sure that helps you to sleep a little better at night, so great. We're now moving to Diane Havlier of the University of California, San Francisco. She has important new data from a really, I think, world-renowned study now known as SEARCH, a community cluster randomized study in Uganda and Kenya. This study evaluated whether a multi-disease streamlined care approach to HIV test and treat could reduce HIV incidence and improve community health. So over to you, Diane. Thanks for being here.
Thanks very much and good morning. So we conducted a 350,000 patient study in rural Uganda and Kenya. And as Linda Gale said, we sought to ask the question, taking a multiple disease, not just HIV alone approach with patient-centered care, how could that reduce HIV incidence and improve overall community health? And in order to do our baseline HIV testing, we conducted multi-disease health fairs where we offered services for HIV, diabetes, hypertension, malaria testing and treatment, and other health services, which was designed and very well received by the community. So these are the main results of the study. What we found out in terms of the cascade, after 1 year in our intervention arm, we rapidly ramped up and essentially achieved 90, 90, 90. So we were able to do this very, very quickly. And by the end of the 3 years, our overall viral load suppression, including people that were migrating in, was 79% and 10% higher if we just looked at the people that we started with. So that was very successful. How did this translate into health outcomes? Well, when we compared our intervention versus our control arm, we saw a 20% reduction in mortality. At year 3, there was 59% less annual TB case rate. And on a population level, hypertension control was 26% better. So alongside with this, we showed that in our intervention arm, that HIV annual incidence went down by 30% over the course of the study. Not surprisingly, when we compared this to our control arm, where we had captured 90% testing when we started the study, and we incorporated the new guidelines that happened over the course of the study, we didn't see any difference in incidence, but that's because it went down in both arms. So what does this mean? I think this means that a multi-disease approach to HIV test and treat search is a HIV out of a silo. So this works and can accelerate reductions in mortality, reduce TB, and is associated with a reduction in HIV incidence. But as we've heard, it did not eliminate all new HIV infections, and it's also a call to more innovations in programs, more research in both treatment, populations such as youth, and in prevention, in what we believe should be going forward, this multi-disease and multi-financed approach. Thank you.
Thanks, Diane. Next up is Dr. Mkhetsi Joseph Makema of the Botswana Harvard AIDS Institute Partnership. He, again, I think, has impressive data from a study known as YATSI, which evaluated the combined impact of several HIV prevention strategies in Botswana. Dr. Makema.
Thank you, Chair. It is a privilege to be here talking to you about the Botswana Combination Prevention Project. And this was a project that was actually sponsored by CDC through PEPFAR. It included the Harvard T.H. Chan School of Public Health, Centers for Disease Control, the Botswana Harvard AIDS Institute, and the Ministry of Health in Botswana. And the study has been ongoing from October 2013. We completed the study in March and follow up in June 2018. The study was to determine if a combination of proven HIV prevention interventions could reduce population-level HIV incidence within a pair-matched in Botswana, 15 in the intervention and 15 in the standard of care. And they were randomized to receive a package of prevention interventions in the intervention community, whilst the other 15 just received standard of care. We conducted the study in approximately 10% of the Botswana population, and the population of Botswana is 2 million, so the communities involved were 180 in total, the population for those communities. Most of the interventions we know, and they include expanded HIV testing, facilitated linkage to care, with expanded rapid access to antiretroviral treatment, and of confirming somebody to be HIV positive. And in order to measure the impact of the HIV incidence, we followed a cohort of HIV negative individuals who were aged 16 to 64 in a randomly selected approximately 20% of households in each of the randomized arms. HIV testing was done annually over a period of 30 months to determine the HIV incidence. And the testing was done by a team of research assistants in the homes of the participants. Our results reveal in the intervention arm, 57 individuals became HIV infected, whilst 90 in the standard of care became HIV infected. And this translates and is equivalent to reducing HIV incidence by at least 30%. We were also able to demonstrate at the end of the study that we could actually increase the cascade of persons identified to be HIV infected, who were started on antiretroviral treatment and having viral suppression. This is the product of the 90-90-90 overall, to 88%. Of note is within Botswana, we already had very high coverage. And at baseline, we already had a 70% covered as per this cascade. But we were able to increase by 18% further within the intervention arm. We believe that our key challenges as we move towards containment of the HIV epidemic is finding cost-effective strategies for the diagnosis and provision of antiretroviral treatment at community level, and developing such strategies for those persons who we don't easily find within the home, such as men and other various mobile populations. But in conclusion, our study demonstrated that at community level, you can actually introduce various interventions, and if at all you go into rapid testing and initiation of antiretroviral therapy, we believe that you can reduce community-level HIV incidence. And I thank you, Chair.
Thank you very much, Dr. Makema. Our next speaker is Valepi Okelo. She comes from the Ministry of Health of the Kingdom of Eswatini, previously known as Swaziland, and she'll be sharing results from the world's first implementation trial of universal test and treat in a government-managed health system. So just to remind everyone, universal test and treat means offering antiretroviral therapy to everyone living with HIV, regardless of CD4 count, immediately after diagnosis. Valepi, please.
Of ages 18 to 49 years were living with HIV. As a country that was severely hit by the HIV epidemic, Eswatini embarked on an ambitious journey towards achieving an AIDS-free nation. Since then, the country has seen a reduction in new HIV infections by 44%, and MaxArt project had a contribution in this. In 2011, offering HIV treatment regardless of CD4 count was still considered challenging and unaffordable. But under the leadership of the Ministry of Health and with courageous entrepreneurship of AIDS funds, Clinton Health Access Initiative and the Dutch Postcode Lottery, we initiated the MaxArt project, which means maximizing art for better health and zero new HIV infections. MaxArt included a multidisciplinary team of government programs, NGOs, non-governmental organizations, community-based organizations, networks of people living with HIV, and research institutes. This team or consortium worked together to improve the uptake of HIV testing, care and treatment services, and to demonstrate that early access to art could significantly improve the health of people living with HIV. The Max Art Early Access to Art for All implementation study tested the real-life implications of providing early art to people living with HIV through a government-managed health system of Eswatini. 3,405 eligible clients were enrolled into the study from September 2014 to August 2017 in a stepped wedge design. The overall results of the study show that early art is acceptable, feasible, affordable, and improves the health and well-being of people living with HIV. In the clinical component of our study, we found that there was a significant difference in the 12 months retention for those on early art and for those compared to those in the standard of care. The retention rates for those who started art early was 86% compared to those who remained in the standard of care, which was 80%. There was no significant difference in costs. Thus, while we were able to retain more people, more clients in care under early access to art, for all, the cost per patient per year was the same as the standard of care. This study proved that the concept of treatment as prevention works, not just in a research setting, but on a large scale in real life. It strongly supports the scale-up of antiretroviral therapy, of early access to antiretroviral therapy in Eswatini and countries with similar HIV epidemic and with health systems that are similar, which then also opens an era towards the possibility of ending AIDS, HIV and AIDS in our countries. Thank you.
Thank you very much indeed. So I really want to congratulate some countries from Africa who I think have, and researchers who've run some really impressive studies and I think are presenting important data here today. Our last speaker, Alan Achesa Malechi, is the founding executive director of Kenya Legal and Ethical Issues Network on HIV and AIDS, or KELAN. KELAN is internationally recognized for its work to advance the rights of those affected by HIV and TB, and we want to once again congratulate Alan for receiving the prestigious Elizabeth Taylor Human Rights Award on Monday night. And I'm going to ask him to just make a few remarks, perhaps the most burning issues, because it is really important that as we do our work in Sub-Saharan Africa, that we pay more attention to human rights generally and advancing the rights of people affected by HIV across Sub-Saharan Africa. It's a broad topic, so I'm going to ask you to focus on just some urgent issues that are on your heart. Thanks.
Thank you, and I will only focus on 3 very burning issues, but before I do that, I must definitely commend the successes that are made in the continent that I come from and also from a region where I stay, and we've got a high burden of HIV and TB affecting adolescent girls, young women, key population, and even men. So I'm really grateful to hear about the scientific developments, the new models of care, but as ever, we must remember and know that nothing will ever be successful in our fight to end HIV, TB, and the other diseases unless we respect human rights, we treat people with dignity, and we meaningfully involve those who are affected by the diseases we are fighting. By meaningfully involving them, it means in the design of your interventions, you need to ask them, they must be comfortable, and they must be willing to have uptake of those particular interventions. 3 burning issues that I've seen, not particularly related to this advancement, but generally in our work in Africa on issues of HIV, is the low investment on the removal of structural barriers or legal barriers that affect people to uptake some of these good scientific advances, some of the programs. Fighting stigma by giving education to communities, working with the media to deal with issues of stigma are things that are missing. supporting legal access, because you'd have women who you want to come to the clinic to test, but maybe their husbands have died and they have been disinherited of their property. They may not be in the right mind frame to be able to adhere to treatment unless their legal issue is taken into account. So it's important that as we continue with the biomedical interventions, we also take into account what investments are we making towards removing the structural barriers that would affect people to be able to access treatment. I spoke about some of them yesterday, including the issue of criminalization of deliberate infection, and I talked about the case of a woman in Malawi who was jailed for 3 months because she was living with HIV on ARVs, but because she breastfed a child who was not hers, she was charged with negligently infecting someone with a disease. And so some of these examples demonstrate that with funding, and the Global Fund has demonstrated that with funding you're able to fund some of these structural remedies and ensure that these are taken into account. The two last points I want to raise is relating to TB, which has been mentioned here, that the fact that the last time it's taken us 50 years to get new drugs, the drugs people were using before subjected them to having side effects, including losing their ability to hear. So we know there are new drugs. We commend South Africa for rolling out the new medicines. We commend them for reducing the prices, but more needs to be done to be able to reduce the prices so that it can be affordable to all. I don't think anyone in this room would ever dare take medicine that has the risk of making you lose your ability to hear or your ability to listen to other people. So looking at it from a human rights perspective, everyone has the right to the highest attainable standard of health. And as leaders will gather in New York in September, this is a chance for them to take a bold decision with a political declaration on TB and ensure that they speak strongly to the issue of access to treatment. I want to conclude by touching on what I would call a fairly sensitive topic. There has been a lot of advancements in new technologies, and as usual, technology moves faster than the law, because largely lawyers are a bit slow and boring, and scientists move a bit faster. But sometimes it moves too fast, so the ability of the law to regulate them, it becomes difficult. And while donors can and should develop better data to target programs for those left behind, there are real and serious risks in the use of things like biometrics, especially for key populations who are criminalized and who sometimes are marginalized. We appreciate the importance of using these methods, but our call is that these populations must be consulted, they must be meaningfully involved, and we must balance around the risks of a person who's dependent on life-saving treatment while you want to capture their biometrics data. We are not opposed to biometrics, but we are concerned that it raises serious risks, and we need to take that into account. I'd like to end by saying that it is possible to end HIV, and yesterday when I spoke, I referred to the new Bible or Quran for human rights, and this report by the Global Commission on HIV and the Law speaks to the progress that has been made since 2012 on human rights, public health, and law interventions. I urge you all to go to the website, download it, and it'll be able to give you the story of how we have been able to advance and make changes. There's a quote and a graph that demonstrates if you have the right legal policy environment and you enforce the positive laws in a positive way, you could halve the new infections of HIV, and we could finally be able to end epidemics, not with science, not with medicine, but just having the right legal enabling policy environment. You could actually halve the number of new infections of HIV. Thank you for allowing me to be here.
Thank you, Alan. Right. I'm conscious of time. I'm going to ask for questions now. As usual, I'd like you to go to the microphones, identify yourself and where you're from, and direct your question to an individual. Please keep questions short because we're a little out of time. So microphone 2.
Thank you so much. I'll try to keep it short. My name is Maureen Luba. I'm from Malawi, and my first question goes to the first presenter. I just wanted, you talked about the slow progress towards achieving the target specifically for young people. I just wanted you to comment on what has been the impact of the current interventions that are focusing on young people. We know of the DREAMS and the AGY debut programs funded by the Global Fund. Can you comment on that? What is it that we are doing wrong, and what is it that needs to be done differently? And the second question is for the presenter who presented on NAFIA. Impressive results indeed. You talked about the 77% overall viral suppression. I just wanted to get a feel, is this the same trend across all the populations? Because you just talked about women. Is this the same trend among key populations, for instance? And lastly, for the presenter who presented on SAGE, given the current trends in funding, I just wanted you to comment on the cost effectiveness of this approach. Thank you.
Alea?
Yes, sure. Thank you for your question. In our model, we did not model the current interventions for children and young people. That is next on our agenda for modeling. However, our model does show that we're off track for start-free goals, which is to reduce new infections among children to 20,000 by 2020. And for stay-free goals, which is to reduce infections for adolescent girls and young women to 100,000 in 2020. So we're far off track for those goals. However, if we meet those goals, then for 2030, the future looks much more bright, and an AIDS-free generation would be much more possible. Thank you.
Bernard?
Yeah, thank you very much. The 77%, it's an overall population result as modeled by the NAFIA study. It didn't desegregate. So, and the study didn't particularly categorize people as key population intent because it's just an overall population based. But as I have mentioned, the women have already reached basically all the goals. And we must remember it's the first study that is conducted in Namibia, population-based, and we look at further studies after this. We look at maybe pediatric in the future in detail. We look at key population. We look at much more detail. So the 77% is overall of the finding of the study.
Thanks, Bernard. Diane?
So what I can say about costing, the community health fair approach that we did, it only cost $1 extra per person to add on hypertension and diabetes screening. Our streamlined patient-centered care approach, we just published a paper that it's in line in terms of the cost of all the other programs right now that have published their cost. And when it's patient-centered, it really speaks to what you said. We worked with the clients before we started the study, and the things that we did were, for example, logistics, making the hours more flexible. The providers were part of the problem, how the patients were treated when they were there. And by using this multiple disease approach, our qualitative data tell us that reduces stigma at least a little bit for people participating in care.
Heather Berner from Medscape. Congratulations, Dr. Hafiku. I wanted to ask, I don't think I understand the context of your program, so I'm wondering what were the steps that led to these results, and how much do you think treatment as prevention was part of this? And Mr. Maleche, I wonder what you think of the whole move of people using U equals U to address HIV criminalization laws. Thank you.
Bernard?
Yeah,
Go ahead.
all right. Yeah. No, thanks once again. I have technical people here in the audience as well. If anyone wants to add, can. This is a study to assess HIV impact nationally. It gives a lot of data besides just impact assessment. It gives the incidence, it gives the current prevalence, it gives a whole lot of data actually. And we have a presentation tomorrow, which I will do at 4:30 tomorrow afternoon, so we will say a lot more on that. You see, we have been getting our data only from extrapolation of antenatal sentinel surveys, which was, as we all know, it's not as accurate as population-based surveys, even though this one, it look at not necessarily just the prevalence of the incident, it looks at the impact of the programs. But in there, we actually pick up a lot of positive information, even on prevalence. and even on incidents, even on viral suppressions, all of these things, because it was fairly an intense, very, very intense study. But the primary objective is to look at the impact of the programs, as I say, and then we pick up a whole lot of other things. We didn't stop preventions while the study is ongoing. All other programs have been ongoing as usual, so there was no disruption, and that includes key population. In fact, I was labeled by the media in a cartoon carrying a condom to prison because I was fighting that condom must be made available even in prisons. So there's no disruption.
Yeah, I love that. So David, maybe Alan, that's a good segue to that. If you can just keep it short, because I see a couple more.
True, but I'd have to congratulate him because it's not every day a Minister of Health pushes to have condoms in an African prison, so well done. So quickly to your question, yes, it's a demonstration of how science is moving faster than the law, and that is welcome science, but it's not the only thing to rely on. We need to invest more in training judges, lawyers, communities to understand their rights, so that even when the cases come before the court, if someone who's unable to get viral load testing, if someone's unable to get ARVs, that is not the only consideration that's taken into account. So more investments need to be done in the judicial system for them to understand the science, the public health, and the legal rationale around the use of some of these laws and their danger, their broader danger to the epidemic. Thank you.
Thanks, Alan. Number one.
Hello, I'm Aisha Majid from the Daily Telegraph, and my question is for Dr. Hafiku. What would you say have been what's been the secret to Namibia's success, and is there anything in there that sort of other countries in the region can learn from?
Well, maybe luck and everything combined, but you know what really happened is that with the help of PEPFAR, CDC, and other partners, we identified what we call the hotspots, regions, and you know, Namibia is a vast country, even though it only had 2.3 million people. It's about 882,000 square kilometers. So we identify 4 or 5 out of the 14 regions as higher incident, higher prevalence area, one of which is the Horn of Namibia, if you know the map of Namibia, that is bordering 4 neighboring countries. And with help of US government through PEPFAR, we target those areas. This is now the program of testing and getting people or linking people to care and treatment. And at the same time, the study was ongoing. So we were reaching out basically on national program with the help of PEPFAR, and the study then went on while we are doing all of this. And we have adopted our guidelines to treatment immediately after testing. So all of these things help us so greatly. Obviously, because we were using Sentinel data, we didn't know much of what we know now. So the study, the very nature of the study being population-based, helped us quite a lot. And that is maybe an element of luck as well. I don't know. Thanks.
I would also add that during this time, battling all kinds of other outbreaks and epidemics, so double congratulations to this Minister of Health. Number 2.
Yeah, my name is Olabisi Adeshino. I'm from an African media organization based online and in the UK called Alternative Africa. I'd like to congratulate Alan Malache for your award and coming to you as an African. Congratulations once again. My question has to do with Africa and having, enabling laws. You talked about it. Can you briefly mention what countries in Africa have enabling laws that, is positively affecting, people living with HIV/AIDS in Africa? Then you also talked about South Africa and the medication has been made available and the effects it's the effects it's having on people living with HIV and AIDS. Can you briefly look at how it's affecting them when it comes to their mental health? Because here at the conference, not much has been said about HIV, AIDS, and mental health. And we know that's beginning to come up when it comes to HIV and AIDS. Thank you.
Okay, real quick, I think there are many countries that are good examples in Africa with enabling HIV or have got good laws. quick example I would go to is the East African HIV law. And why do I choose that? It's a regional law that is binding to all the 5 East African countries. And what's amazing about this law, it overrides all the other laws in the 5 other countries. But having looked at the issues of adolescent girls and young women, this is a law that clearly spells out that you must provide sexuality education to adolescent girls and young women. You must provide reproductive health care services, and that is a law that is going against the gradient of what happens in some of our African countries. So there are many laws, and that's one of them that you can look at, and I'm happy to discuss more. On your last question, it is true there are issues of mental health and HIV. They may not have been discussed much in this conference, but in relation to TB and the medicine I was talking about, it was largely a new medicine called bedaquiline, which has now been licensed to be used in South Africa. Other countries like my own are still waiting, and we are happy because this medicine will help reduce the side effects people with TB were facing while they were using older medicines. The only concern we have is around the price, and we need pharmaceutical companies to lower their prices so that people can be able to afford.
I'm just looking, I'm going to allow only John, I'm afraid. I'm really sorry, we're out of time. So, John, if you could just...
I'll be brief.
Yes, please.
John Combe with Science. 90-90-90 is a model, and you now have some data from Namibia and from Search. Can you speak to whether the model's prediction of what would happen to incidence matches what you've actually seen?
Well, not being the scientist myself, but you see, if we're talking about reduction of incidence by almost 50% in the last 5 years, and we have already surpassed what has been the milestone by UNAIDS, I don't see anything that will stand in our way in reaching our primary objective. I think everything is realistic and is reachable. That's my view. But if there's anyone in the audience who want to add something, it's welcome today. But that's the way I look at it.
Thanks, Bernard. Search was mentioned. I don't know, Diane, if you want to sort of comment as well from your perspective.
Right, sure. I think the overall concept, as we ramp up ART, we are going to see reductions in HIV incidence. But then it's affected by various aspects of an epidemic, such as sexual networks in certain geographic regions, that is going to give us heterogeneity. So I think that's my answer, is that overall, yes, but we need to understand much more about transmission, and we know we have gaps with youth in order to fully realize the benefits of that model.
Good. Well, that concludes... Dr. McKemmer wants to...
Let me just quickly, on the 90-90-90, I think from my perspective, I've always understood it that it's a target which is set for 2020. And that if at all you sustained viral load over the overall cascade, it's only by 2030 that you would attain epidemic control. So it's really about the sustaining of these targets that have been set over a 10-year period, that at the end of which, at 2030, would you then be able to say, indeed, we've been able to attain epidemic control.
Great. I want to thank a brilliant lineup of speakers. I know these are great studies. They're going to be discussed in more detail. Thank you to all of you and to our speakers.